So without any further ado, we're going to start the session. There's no one better to start it than Dr. Sunil V, who is professor of medicine at Duke University and chief of cardiology at the VA there, who's going to talk to us on a topic that he's been leading for many, many years on state-of-the-art antiplatelet therapy 2016.
Take it away, Sunil.
Thanks so much. Thanks again for the invitation to this wonderful meeting. I mean, it's just really amazing, the breadth of expertise. So I've been given the charge of talking about state-of-the-art for antiplatelet therapy, and I think, a few years ago this was a relatively easy topic to talk about, but now things have gotten quite a bit complicated. We were so focused on in-hospital care in the past, and they had very, very few options, but now we're starting to think about patients as they go home, and long-term secondary prevention. We're starting to think about vascular disease and how we can prevent major adverse cardiac events in patients who don't have coronary disease but may have manifest PAD. These are my disclosures. So let's start off by talking about why we're worried about antiplatelet therapy in the first place. And this is obviously review for all of you, but I think it's important to understand that platelets are a primary target of our primary treatment for acute coronary syndrome and a primary target for secondary prevention in patients who have a history of atherosclerosis. And the cross-section of the coronary artery that you see there on the right shows that ruptured plaque leads to activation of platelets through the generation of thrombin. And so inhibitors of platelet activation and inhibitors of platelet aggregation ultimately lead to improved clinical outcomes, with the caveat that they do increase bleeding risk. And so throughout this talk, we'll talk about the balance between bleeding complications and a reduction in ischemic events, and how we can try and achieve that in each individualized patient. So what did we know about the risks and benefits of antithrombotic therapy before today? Okay, so let's start about what we started with in terms of our knowledge, and then we'll talk about what we've learned in the past several years. So we know, I think, based on prior randomized clinical trials and observational data sets, that as you increase the potency of antithrombotic therapy, in particular antiplatelet therapy, ischemic events decrease and bleeding events increase. That is the fundamental challenge that we're facing at the bedside. How many of you in the audience, when you're seeing a patient with acute coronary syndrome in the emergency department, will load patients with an oral antiplatelet agent other than aspirin? So a few folks who've had enough coffee are willing to raise their hands. So if you look at the national data, about 55% of ACS patients will be preloaded before the cath lab. We didn't have a lot of solid data on the duration of antiplatelet therapy after PCI or ACS. The 2006 consensus statement from the ACC and the AHA said that you should leave people on for at least a year, maybe 2 years, and this is, of course, because of the PTSD that we all had from stent thrombosis with the first-generation DES. And many of my non-invasive colleagues now still ask me to put in bare metal stents in patients because they're worried about adherence to DAPT. And I hope that during our panel discussion, we can talk about what the role of bare metal stents is in the current era. And then there was no solid data on the role of antiplatelet therapy in vascular disease. We all treat patients with aspirin, but a large meta-analysis showed that aspirin is not beneficial in patients who have PAD. So that's where we started. And so now let's go through some of the data. What are we worried about in 2016? Well, amazingly, we're still worried about the same things. How long do we treat patients? And Dharma and I are going to have a debate about the duration of antiplatelet therapy. We're worried about triple therapy, right? A lot of patients now with atrial fibrillation, valves, who are developing coronary disease, and we're putting stents in them. We still are having the debates about preloading. How long should we treat patients? And then what do we do after a year? Why is it that the 12-month cutoff is a line in the sand? Do we just take patients off of antiplatelet therapy because they're, quote, cured? And then we'll talk about PAD and vascular disease. So let's talk about the DAPT trial. This is really one of the major landmark trials that has come out in the last few years, designed to answer, I think, a very specific question. So we have to be careful that we don't broaden the question and the hypothesis that the DAPT trial was designed to answer. These are 20,000 patients with drug-eluting stents or bare metal stents who were event-free at 12 months. So no ischemic events, no bleeding events, and then they were randomized. They were eligible for randomization if they had no death, obviously death, you don't want to randomize a dead patient, MI, repeat PCI, or bleeding, and they were randomized to stopping their P2Y12 inhibitor. In this trial, it was only clopidogrel or prasugrel. Ticagrelor was not represented in this study. Or continuing DAPT in a blinded fashion for 30 months. So the treatment period was 12 to 30 months. The overall observation period was 30 months. The co-primary efficacy endpoints were stent thrombosis and MACE. with death, MI, or stroke, and the primary safety endpoint was gusto severe or moderate bleeding. Now, I will editorialize for you here a little bit that gusto severe or moderate bleeding is a very severe bleeding event. Okay? It involves transfusion, intracranial hemorrhage, or bleeding leading to hypotension. For those of us who take care of patients, we know that the majority of bleeding events would not meet criteria for gusto moderate or severe. So what did the study show? Well, it showed something that was also reflected for you on this meta-analysis, which is that with a prolonged DAPT after DES, if you include the DAPT trial, along with 9 other randomized trials, all of which were much smaller, you see that there is a strong relationship between prolonged DAPT and a reduction in myocardial infarction, definite probable stent thrombosis, with an increase in bleeding risk. Okay? So longer therapy reduces ischemic events, but does put patients at risk for bleeding. We can now try to individualize therapy, because again, that's the randomized trials give us the average result for the patients, but at the bedside, we're forced to make decisions about the individualized patient. And Bobby Ye took the DAPT trial, did a series of very sophisticated analyses, and developed the DAPT score. I will tell you that the concept of the DAPT score was originally proposed by Subhash. Back in 2005, he was talking about developing a DAPT score. So this is not a new concept, but it was put into reality by the DAPT trial and the fact that there were 20,000 patients. And using a series of patient variables that you can see on the left-hand side, such as age, diabetes, smoking, prior PCI or MI, heart failure, or a reduced ejection fraction, you can develop a score, tally that up, and figure out whether the patient would be at increased risk for ischemia or an increased risk for bleeding, and theoretically individualize antiplatelet therapy. So the scores add up to, basically the cutoff is a score of 2 or greater. So if the DAPT score is less than 2, then there are net adverse events. The risk difference between thiopyridine and placebo at 12 to 30 months is higher. If it's greater than or equal to 2, it's lower. So you can use that to try and decide which patients should be treated with prolonged dual antiplatelet therapy to reduce ischemic events, and which patients can potentially avoid it because of increased bleeding risk. So this is really the first step into individualized therapy, with the caveat that the C statistic for this model is actually not that great. The C statistic is basically, if it's a 0.5, that means you're flipping a coin to figure out which patients are being identified by the model. This is about 0.7, which is moderate. It's not great. So what that tells us is that these patient characteristics alone are probably not sufficient in all patients to help us understand which patients can benefit. But I think this will continue to be refined over time as we develop newer and newer risk models. Let's talk about preloading. So again, we're big believers in preloading at our institution. We felt that getting the therapy on early would potentially prevent downstream ischemic events, and this was tested formally in the ACOAST trial with prasugrel. So these are 4,000 patients scheduled for angiography or PCI who were given 30 milligrams of prasugrel pre-angiography or 60 milligrams of prasugrel at the time of PCI. The PCI was at a median of 4 hours after the initial dose, about 4 hours of preloading, which should be sufficient to get antiplatelet effect. But look at the curves on the left. The primary endpoint of cardiovascular death, MI, stroke, urgent revascularization, and the need for 2B3A were completely overlapping. There's no difference. So this really surprised everybody, and it's possible that in this patient population, the overall risk is sufficiently low that simply changing the timing of loading by just 4 hours probably doesn't make a difference, but it clearly increases bleeding risk. What about the use of ticagrelor? So in the Atlantic trial, these are STEMI patients, the patients in whom I'm actually very, very meticulous about preloading. Turns out that in the overall endpoint of ST segment elevation resolution or absence of TIMI3 flow, it doesn't make a difference. What it does make a difference in, potentially, is definite stent thrombosis at 30 days. So like all pieces of evidence, we tend to believe ones that are consistent with our preconceived notions. So I use this trial to say, yeah, I still believe in preloading because it seems to reduce stent thrombosis in patients with ST elevation MI when ticagrelor is the agent. No difference in protocol-defined major bleeding between the groups. Again, both groups got ticagrelor. So this is potentially an area where cangrelor may have a role. You are familiar with cangrelor, the ultra-short-acting intravenous P2Y12 inhibitor. Interesting series of trials, 2 negative trials, and then a third one that was redesigned that was positive with respect to the primary endpoint of 48-hour death, MI, ischemia-driven revascularization, or stent thrombosis. The primary difference here was in intraprocedural stent thrombosis with a relatively modest effect, but this drug is now available, and people are getting more and more experience with it, and this may be particularly beneficial in the kinds of patients that we were talking about last night who are in shock, who are unable to take oral P2Y12 inhibitors. So more data coming on Cangrelor as people start getting more and more experience with it. But now let's talk about the ACS patient who's now 12 months beyond their ACS event. First, let's talk about Trilogy. These are patients who were medically managed with their ACS. So they were started on antiplatelet therapy, clopidogrel or prasugrel, in the hospital before they were discharged from their ACS hospitalization. The primary endpoint of cardiovascular death, MI, or stroke. There's a different dose of prasugrel used based on age or patients less than 60 kilograms. I don't know about you, but I don't think I've ever had a patient that's less than 60 kilograms, but I guess they're out there. In this study, interestingly, the curves did not separate until at least 1 year post-ACS. So the overall trial showed that there was no significant difference. The p-value was 0.21. There was an increase in bleeding numerically, although the p-value was non-significant. What's interesting here is that the curves start separating at 1 year. Okay, so potentially, if we waited a year after ACS and then randomized the patient, we could see differences. And sure enough, that's exactly what was done in the Pegasus trial. This is a study with ticagrelor, both 2 different doses, 90 milligrams BID and 60 milligrams BID. These are patients who were stabilized from ACS and who were 1 year out after their acute coronary syndrome hospitalization, who were randomized. And in this study, both the 60 milligram dose and the 90 milligram dose were beneficial at reducing the risk of cardiovascular death, MI, or stroke at a risk of increasing TIMI major bleeding. So if you look at the net benefit per 1,000 patients, with the 90 milligram dose, it reduced 12 MACE events or an increase of 15 bleeding events. Now let's talk finally, to wrap up here, about vascular disease, because this is the rapidly growing population. We know that the event rates are incredibly high. About 1 in 5 patients will have an increase in adverse events if they have PAD, primarily because they probably can't walk enough to manifest angina. And so they have very, very advanced coronary disease. We know that clopidogrel alone, compared with aspirin, reduced modestly the risk of death, MI, or stroke. This is single antiplatelet therapy. So Brilakis is a drug that was studied in the TRA2P trial, where the benefit was primarily seen in patients with vascular disease, where it reduced the risk of cardiovascular death, MI, or stroke by an average of about 13% or so. But again, the trade-off is increased bleeding. So for every 16 cardiovascular death, MI, or strokes prevented, you had an increase in 13 gusto, moderate, or severe bleeds. And in particular, you do have to be careful in patients who have a history of stroke, TIA, or ICH. The drug really should be avoided. We'll have much more data on the PAD population in the Euclid trial. My colleague Manesh Patel is running this trial, a very large study with ticagrelor alone versus clopidogrel alone. This trial will hopefully be presented at the AHA this year. So what do we now know about antiplatelet therapy? Again, unfortunately, we're still stuck with the same balance. Longer duration of DAPT reduces ischemic risk, but increases bleeding risk, potentially mortality, although that's not clear exactly why. The DAPT score may help us individualize therapy. No compelling data, really, for routine preloading, although ticagrelor in the STEMI population may reduce stent thrombosis. We know that ticagrelor for long-term therapy post-ACS reduces MACE, but again, increases bleeding. Similar effect that was seen in the Brilakis data, and I think the Euclid trial will be very, very informative. Thank you very much.